So good evening, everyone. So we do have some good news to present as we move into this meeting. First, we just wanted to give you some updates in relation to some items that are going on with the state health department and maternal health. So,
Go ahead, Joyce.
task force update. Sorry, the screen changed on me. I thought I was losing everyone. So we have with our county prenatal care gap filling clinics, they've now expanded to 9 counties and with 3 additional that are currently in process. So that'll give us 12 counties that those will be in throughout the state to kind of help fill that gap. Also, the STAR Clinic continues to grow with high percentages in prenatal visit attendance, engagement in substance use treatment program at time of delivery, and of course, what very important that the infant's discharged home in the custody of the parent. The aspirin therapy initiative, which I know Melissa is going to speak further about in a little bit, continues to grow, expand, be in high demand. We're getting all sorts of engagement, social media action, people downloading the materials and information, engaging, asking questions, and pulling together that information. It has been so high. Cox Media is giving it rave reviews, who we're working with to do it. It's high above the industry standard and really getting lots of interest throughout the state in relation to the aspirin therapy. Also, we have had close to 200 more enrollees this last year in the Speak Up Racial Disparities training. So that continues to be a popular event. We're very excited about an initiative we have working together with our Medicaid agency on family planning coverage. So that should take effect this month. We're just waiting for final approvals. We have all sorts of materials and information ready to go as soon as that does receive that final approval and is released hopefully later this month. But it will move the sooner plan back, and that'll move it from the 138% federal poverty level rate to those that will be able to qualify up to the 210% federal poverty level rate. So that is very exciting. We'll cover a lot of people that were missing out on coverage and services due to not falling within that original qualification. So we're very excited about that and the services that will be able to be available to many more Oklahomans in need of those services. And finally, just want to do a plug, but I'm not going to steal the thunder. I'm just going to kind of do a teaser. We have some really exciting news in relation to our teen birth program that we work so closely with Oklahoma Perinatal Quality Improvement Collaborative and RIOD out of Harvard. Some really exciting news about statewide initiatives. So please stay tuned for Barbara's information coming up in just a few minutes in relation to some outstanding news about new and upcoming events on teen birth and accomplishments in that regard to that program. And I think that is all I have. Are there any questions? All right, thanks everyone.
Thank you, Joyce. And next, we have some updates from Traylor Rains, who is our state Medicaid director. Lots of changes coming in 2024. So thank you, Traylor, for being here with us this evening.
Indeed. Good to see everybody. So I'll just kind of give a recap on how we ended 2023. As you recall, we have been unwinding after the public health emergency ended, all of those individuals who no longer met eligibility criteria to be on the Sooner Care program. So December 31st was our last cohort of the portion of the population whose eligibility is administered by the healthcare authority. So that's everyone that would get their eligibility through mysoonercare.org, like our pregnant moms, our kiddos that are non-disabled, as well as our expansion population. So our final numbers for the MAGI population for unwinding was 267,220 individuals who lost coverage over the course of 2023 for no longer meeting criteria. We're in the process of kind of just doing a postmortem review of the unwinding process, kind of seeing what worked and what didn't in terms of communication, where our procedural termination rates kind of landed, and how we can maybe improve our steady state churn moving forward. So into 2024, we did start open enrollment for our dental, our Sooner Select dental benefit plan December the 1st, and that actually ended on January the 10th. We had about 11% of our population actively chose a dental plan, or as we were saying, pick a plan that fits. So they've chosen that plan for them and their family. There was roughly 90,000 individuals who actually actively chose a plan during open enrollment. The rest of those we have auto assigned for a plan. That auto assignment is complete, and through that algorithm, we're making sure that we're keeping families together and aligning them with the same plan where we can. And so now from there, we're giving those assigned individuals over to our 2 dental benefit plans, and they will then start sending out welcome packets and getting those folks onboarded. There is a 90-day period to where once the member is assigned to that plan, they can change their mind and choose the other dental benefit plan. But after that point, they're going to be locked in until the next open enrollment. There are some good, I'll start dropping links on in the chat. We have updated our website. Well, we continue to update our website as things are unfolding in the Sooner Select world, but I wanted to make you aware of, as you recall, one of the great things about going to Sooner Select is the value-added benefits that we can bring in for the members that we serve through our contractors, which are things that we just can't provide in a fee-for-service world. So we're really close to finalizing the medical value-added benefits. The link I just dropped there is our extra benefits chart specifically for dental. Which specifically in this space, Liberty Dental, as one example, offers for pregnant moms a home delivered meal option that delivers them about 10 different healthy meals throughout their pregnancy, and really education around nutrients and nutrition during the pregnancy and postpartum period. There's lots of great stuff to come on the medical side in terms of value-added benefits there. Open enrollment for, as you can see in my background, open enrollment for medical is right around the corner. It starts February the 1st, and we'll go through March the 10th. And then on March the 11th, we're going to do a very similar auto assignment to the 3 medical plans, and make sure that everyone is aligned with the plan so that we go live April the 1st. At this point, we have crossed all of our kind of go, no-go decisions and milestones and successfully gotten there so that we're still all set for launch on April the 1st. So we were talking earlier about what can you do to help to raise awareness. If you visit our website on the, I will drop a link. We have a very robust stakeholder toolkit that gives you kind of language to use if you want to do outgoing messages to members that you serve, if you want to post flyers in your clinic. Let's see. We even have graphics that you can post on your social media just to raise awareness around the transition to Sooner Select for your members and your clients and other providers and stakeholders, and letting them know about the open enrollment period. We're encouraging providers actually to not steer towards a plan, but rather steer members towards mysoonercare.org and our choice counseling options. They can call our hotline. That will actually help members talk through the various value-added benefits for all the plans, help them understand which one really works for them and their family. Our choice counseling line is actually a dedicated line, so you're not going to have to be in the same queue that was handling eligibility questions, which we understand they're experiencing longer than usual wait times because as we were going through the public health emergency unwinding. So if you call that choice counseling number, generally your call will be answered within 30 seconds. Wanted to draw attention to, and I'll drop a link to this as well. Another great thing about moving towards Sooner Select, again, is we can do a lot more in terms of supplemental payments and just other ways of increasing access to care generally. One of those is our provider incentive reimbursement program. So I will say that this is, I just dropped a link. This is pending CMS approval, but essentially through state legislation that allowed the healthcare authority to move towards Sooner Select, hospitals as a provider group have access to the supplemental payment for hospitals. And their supplementals are increasing up to average commercial rate, which in general terms is going to bring about $500 to $600 million additional dollars to our hospital systems through that provider tax program. As part of that, though, the hospitals agreed to carve out a separate pool that would be used to incentivize community non-hospital-based providers to engage in the Sooner Select program. So I've described in the link below, if you see there, the pool is roughly $130 million. So it's $134 million, 330,110. So this, to be qualified for the program, you have to meet the definition of an eligible provider, which is our mid-level. So a physician's assistant, advanced practice nurse, non-community mental health center mental health providers. So if you are an independently contracted behavioral health provider or you are a non-CMHC agency, you'll have access to that. Podiatrists, all levels of physicians, and anesthesiology assistants. So this will be administered by the healthcare authority and directed to the providers through our managed care partners. We wanted to increase access to certain primary care services. So how the program will be distributed, there will be 3 specific services that we'll focus on for a $25 add-on. One of those is the SBIRT service, the screening, brief intervention, referral to treatment. Just by providing that service and submitting a claim in addition to the base fee for that claim that a physician would receive, they'll also get $25 on top of that. The next is any care that's provided after hours to any member that's being served by Sooner Select. Again, a $25 add-on to any after-hour service. And then we also have any well visits that are provided by physicians. And again, $25 add-on. This is not something that the provider has to keep up with in terms of adding it up and submitting claims. All the provider has to do is submit claims as usual, and the healthcare authority will track all of these CPT code billings and then keep a running tally of the various $25 add-ons and then distribute that through quarterly payment distributions to the provider. In addition to that, just for being, I feel like I'm selling a car. In addition to that, there's more. If you are a Sooner Care participating provider meeting the definition of eligible providers, in addition to those $25 add-ons, you will also get a 19% increase on the base fee schedule for any service you provide. On top of that, if you are connected to the Health Information Exchange, the statewide HIE, we will multiply that by 1.5. So I kind of have to see this visually. The math isn't always mathing for me. So to give you an example, if you have a standard office visit that's $100 per visit and you are not connected to the HIE, you'll now receive $119 for that visit. If you are connected to the HIE, you'll be paid $128. Again, that $28 is going to come to you in the form of a supplemental payment on a quarterly basis, in addition to all the other supplementals you may be eligible for. Your regular claims run will still be the base fee that's paid today, but you'll be eligible for all of these add-ons. Our goal is really to increase more access to primary and specialty care, especially in some of those desert areas, hopefully attracting more providers to the Sooner Care Network. So I think that's my overall update. I know I just dropped a lot of information for you, so happy to answer any questions.
Thank you, Trailer. Any questions? We will make sure that we share these links with you in our follow-up email. I'm sure the add-ons are appreciated and the add-ons can add up.
For sure. For sure. It's a lot of money.
So, well, thank you so much, Trailer, for the updates and for joining us tonight. And again, we will share these links with you in a follow-up email after the meeting. And now I'm going to turn it over to Teresa Stevenson, from the Department of Mental Health and Substance Abuse Services for updates from them.
Great. Can you hear me okay?
We can.
Okay, great. I was having issues earlier. So just a few things that are happening coming up in the next couple of months. We have our summit, which is the Family Preservation Strategies for Pregnant People with Substance Use Disorder. And it is March 7th and 8th. It is by invitation only. Around 200 policymakers, judges, child welfare like individuals will be invited to come together. The goal is to decrease criminalization of individuals who are pregnant, postpartum, or had a miscarriage and have been exposed to used or misused substances, provide other pathways to support these individuals in all 5 points of intervention: pre-pregnancy, prenatal, neonatal, postnatal, birth, and early childhood that are not punitive, and break the stigma and myth that all persons with substance use issues cannot be stable, caring, and safe parents to their unborn children. And so all the speakers that we have invited have confirmed. We are still waiting on Lady Stitt, whether she will be or a representative, but we've had overwhelming support with this summit. The first day will be full of information provided by different individuals about Oklahoma's current landscape. And then we will have panels from the different sectors of child welfare, state agencies, Department of Corrections, and a family panel. And on the second day, we will actually have a planning session for the different disciplines to help develop some action steps that they can take to help reduce the potential for individuals being criminalized and or to reduce the need for additional child welfare services. So we're really excited about the work with that. Leading into that, Representative Melody Blanchett is working on a bill that is supposed to be solidified and submitted within the next week or two. I believe they have to have their bills in, and it will be kind of addressing the issue around criminalization and reducing, offering alternatives to the incarceration, and has invited the Department of Mental Health to submit some practices or some services that we believe would be positive for that. And it would be great if we end up getting some financial assistance on that so we can expand a lot of the work that we're already doing. There's nothing written in stone. It's just that is something that is a positive light at the end of the tunnel. And then we have more work that we are doing with pregnant persons with substance use disorder and their families, and that's our COMPASS project, and it's a collaborative Oklahoma maternal pathway to access substance use treatment services. COMPASS is what we call that. And we are currently, the Ponca tribe is doing work with that, K County Comanche tribe, and then Greek Country is doing their kickoff February 27th. And that is implementing the Parent-Child Assistance Program and collecting data on the outcomes of that along with the family care plan. And then we'll also be looking at some other variables such as teen birth and the AIM bundle that some of the hospitals might be participating and utilizing. So we're really excited about that work and really, addressing some of those major issues out in the rural communities. And then we've been doing a lot of work with our Safely Advocating Families Engaged in Recovery, and we have been able to do an additional in-depth technical assistance with the Chickasaw Nation. So it's a collaborative with them. And we are currently in the process of them developing a particular name for the family care plan, really developing and modifying this to fit the culture of their community. And they are working on their current work groups. And so we'll hopefully see additional progress. We had a lot of conversations with their head leadership, and it was very encouraging to see how many people really want to come together to work with these families. So we're excited about that work. Oh, and we are doing Parent-Child Assistance Program trainings for statewide. So it'll be available through a grant that we received. We'll be able to train anyone, any agency or entity that's interested in doing the Parent-Child Assistance Program, which is a 3-year home visiting home visiting program that works with the individual that has substance use disorder. It can be prior to delivery, up to 3 years post-delivery, or post-delivery up to 3 years. And so with that, the training and coaching and consultation will be free to anyone that wants to attend that training and implement that program.
Thanks so much, Teresa. Lots of good things going on. And does anyone have any questions for Teresa? If you do have questions, we will be sending the follow-up email. We can send some information, and if you have questions, you could email me and I can forward them to Teresa. So thank you so much. And speaking of, we do have an exciting update from OPQIC. We are welcoming a new staff member, Evelyn Radishell. Her first day is today. So Evelyn, you heard Teresa mention COMPASS. It's a long acronym, but Evelyn will be our project manager on perinatal mental health and substance use disorder in pregnancy initiatives. And we're excited to have her join us today. So thanks, Evelyn. And we will be introducing Evelyn to everything that's going on right now. I'm sure she's a little bit overwhelmed, but Evelyn is also the section chair of our Association of Women's Health Obstetric and Neonatal Nurses, and is always very involved in our work and as a nurse leader. So we're excited to have her join our team. I have a couple of other updates. Wanted to share some updates on Team Birth with our updated data. So first of all, these are our hospitals that are joining, that have already implemented Team Birth, I should say. We had one of the first 4 hospitals in the country with St. Francis Hospital in Tulsa. 2 other hospitals joined then in 2021 from Tulsa. And then we have been partnering with Ariadne and with support from HRSA and the State Department of Health through the State Maternal Health Innovation Program funding. We have been supporting other hospitals in Oklahoma in a cohort fashion. So you can see the cohort 1 and 2 who have already launched and they're now in sustainment mode. We have the next slide, cohort 3, that launched in March of last year, and cohort 4. Most of them already launched in November of last year. A few of them had to postpone their launch until upcoming in March and April of this year. And then we have a cohort 5 where we're going to get, I said we're going to get every hospital to join. We are only missing one of our birthing hospitals. So, and that's just because I'm hoping it's just because she and I have not been able to actually talk to each other. So we're really excited to have all of our hospitals joining Team Birth. We see this as a way, when it's implemented with fidelity, that hospitals can provide respectful care and provide care that is dignified and equitable. And our data really show that too. When we look at the first data survey, the mother's autonomy and decision-making, we see that when a patient experiences a huddle, those are the orange bars. The blue bars are those who have not experienced Team Birth. You can see those who have either answered strongly or completely agreeing with these questions that are under the bars. So for all of our hospitals, we see an increase. I mean, all of our patients, we are seeing an increase from those who have not experienced teen birth to those who do experience teen birth. And we always, those three on the left side, those are our questions for every hospital that have the lowest percentages, even when they have experienced teen birth, that they were involved in decision making, informed about decisions, explained about pros and cons of options. Some of these might be that they've already made some decisions prior to coming to the hospital, but it is something that we're really focusing on now, is ensuring that we are providing that individualized care, and that patients we are truly providing a shared decision-making model of communication. The next slide has a few other questions. I'm sorry, these slides are the MADAM quartiles by race and ethnicity and huddle status. So Denise, I don't know, the way that you're sharing, it's showing your computer screen and not really the slide, but we will send these out afterwards. But you can see the races there broken down as to how the patients identified and whether they answered a question with very low autonomy, moderate autonomy, or high autonomy. And you can see with those who experience teen birth, the high autonomy increases by almost at least 20 percentage points per race. So this is really exciting data, and there's a lot of interest nationally in this. We were the first state to implement statewide, and hopefully we will truly be able to say that we are truly implementing statewide. But here you can see the increases in those who have said they have high autonomy when they experience teen birth. The next survey that we use is, oh yes, that's better. Thanks, Denise. The healthcare relationship trust scale. We know that particularly over COVID, the trust between the communities and patients and healthcare providers took a hit, and we want to measure trust and whether patients have trust in their healthcare team. So we see on this first slide, these are again the same format as before, and these are the percentage of respondents who said all the time, according to whether they experienced teen birth. Again, there's that discussion option and choices before making healthcare decisions. We really want to see that even those who experience teen birth, we want to see that increase. So we do have monthly coaching calls with those who are currently in implementation status, and we also meet quarterly with all of the hospitals. So we're trying to ensure that we truly are, again, implementing that shared decision-making model. And then the next slide shows our last set of questions for those who answered all the time by huddle status. So we can see again, there's a 15 to 20 percentage point increase for most of these questions, which is pretty exciting data when you look at whether they trust their healthcare team. So excited about teen birth, and hopefully when we meet in April, we'll be able to say, yes, we did get that last hospital, and we've got all 44 of our birthing hospitals that are implementing teen birth. And now I am going to turn it over to Sarah Johnson, our patient partner, maternal peer navigator, who will be providing some updates on the patient partner program.
Thank you, Barbara. I'm so happy to be here and happy to tell you guys a little bit about our patient partner programs. And I love to follow up any team birth presentation because that data is really exciting to me. And the Team Birth Project is really, really exciting to me as a patient and as a mom here in Oklahoma. I think it really resonates with me, and I'm really proud of our team for capturing almost every hospital in the state, and we're not giving up. So yay to that. So anyway, moving on to our patient partner update. I wanted to just do a quick update here on a couple of the things that I've been working on. And first off, I wanted to share this slide this is actually from the Maternal Mortality Review Committee recommendations. So they put out a report. I think it was in the fall and maybe October, I think, Joyce and
Yeah,
Barbara.
November.
November? Okay. And in that report, there are recommendations for how to address things that were identified in the Maternal Mortality Review Committee. A couple of those things I just highlighted here. There are a couple conclusions where the arrows are that delays in medical interventions occurred when complications developed during pregnancy and the postpartum period, contributing to mortality. And the other conclusion here in this section was that opportunities exist to improve the quality of prenatal, interpartum, and postpartum care through communication. And then under those, you can see the recommendations that expand education to healthcare providers, pregnant women, and their families through about pregnancy and postpartum warning signs and how to seek care. Another recommendation there is to increase awareness of possible complications by educating pregnant women and their families on pregnancy and post-birth warning signs, and to promote the CDC Hear Her campaign and encourage pregnant women and their families to speak up and encourage health care providers to listen and respond. So I'm highlighting those things because one of the projects that I've been working on for the last couple years is called the Empowering Pregnant and Postpartum Patients Toolkit. And these recommendations from the MMRC really highlight the need for this tool and this toolkit. And whenever the recommendations came out, it really just solidified the importance of this tool that we've been working on for the last couple years. So when I first started the work working with OPQIC in 2020 and convening a patient partner network, one of the things that we as patient partners identified as a need was we needed more education about warning signs, and we needed more information about resources and how to seek care whenever you might think that something might be going on, or if you just need more information about something during and after your pregnancy. So with the patient partners, we set out to really identify and target and target a few resources that we already knew were out there, and identify ways that we could help providers and clinicians and family members and pregnant people have better access to those. So a few of the things that we identified were that urgent maternal warning signs is a tool that already existed that can help pregnant and prenatal women even identify complications or warning signs that they need to be aware of. Also, the post-birth warning signs was already out there. It's a tool that exists and hopefully that hospitals are using. But we weren't sure because as patient partners, none of us had ever really seen that tool. Another thing that we thought would be helpful is to create some sort of a handout for local resources that every mom could utilize. And then also something else that we all felt really passionate about was that we needed help to to understand maybe what had happened during our birth experience, or even to be able to have quick access to what had happened during our birth experience. So throughout all of that, we came up with a toolkit that includes those resources and then a few things that we created. I'm going to go into some more detail about that on the next slide. So here is the toolkit resources. Like I said, there's the urgent maternal warning signs, the post-birth warning signs, and then a helpful information flyer, which is one that we created as a patient partner network, which includes mental health information, a place to find expert advice that is evidence-based, also breastfeeding resources, and then a link to our website that has a lot more resources for advocacy and connections to support groups. We also created, with the help from OPNF and other hospitals that have been involved in our pilot trial of this tool, we created a birth hospital clinical summary, which is that last tool that you'll see there. That tool is intended to give some basic information to every birthing person before they leave the hospital about their birth experience, in order to help them have access to that information quickly, and also to be able to reference it if they needed to for their own information, or in case they experience further hospitalization or complications after they are released from the hospital. So these are the basic tools, and these tools you can find on our website, and I put the website there for you to access. If you want the tools, you can always access those on our website. However, we identified that just having access to tools is not always the most useful for clinicians and busy people in the hospital, and even for patients. And so we figured that we might need to do a little bit more in order to help patients or to help clinicians utilize these tools to the best of their ability. So what we created is an implementation guide. And actually, Denise, if you'll go to the next slide. Okay, yeah, so this is an example of the implementation guide. This is just one screenshot of one of the tools, which is the urgent maternal warning signs. And I created a live binder. So I don't know if you guys have any experience using a live binder, but basically it's just a link. You can use this QR code to go to the link with the live binder, and it has the implementation guide there for you. So beyond just utilizing our website to get access to the resources, you can go to the live binder and have access to an implementation guide that can walk you through each tool and how to use it. What we did was we really we wanted to identify when it should be used. So for the urgent maternal warning signs, that needs to be used in the prenatal setting. Who is supposed to be giving that to a patient? We identified a few people there that would be ideal. And then we also even came up with some language on how to use that tool. So we did that with every tool in the toolkit. We even included links, and you'll see at the bottom of that screenshot there where it says patient education flyer, I included links that can take you to different languages, to the full website from the urgent maternal warning signs that gives you all kinds of resources, in every language that you can imagine. So our implementation guide just gives you guys a lot more resources and information on how to use the tool. So we did that for every one of them, all the 4 tools in the toolkit. But we also realized that just having access to the implementation guide may not always, tell you everything. I'm a visual learner as well as an auditory learner. And so often I need somebody to explain it to me. And so we are also offering, and I think it's on the next slide, Denise. Yeah, so we're offering support and using the toolkit. So if anybody is interested in having us come or do a Zoom call, we just do like a quick 1 hour Zoom call to help walk you through using the toolkit and identify really your needs and the best way for you to utilize the toolkit. You can go to this, either use the QR code or go to the link, and I can set up a time with you to help you access the toolkit and then walk you through how to use it. So we also are offering that as a service to you guys. And then I think, let's see, the next slide I think is about the patient partner. So I also want to offer an opportunity for anyone to ask questions about the EPPP before we move on to the patient partners. I don't know. I'm not really seeing anyone's off camera yet, but
I don't see any questions. So
okay, great. Thank you, Barbara. I had not checked to see in the chat yet. I was clicking over. If you do have any questions, you can always contact me, Sarah-J-Johnson@ouhsc.edu. And I've shared lots of links here and QR codes. So any of those, you can get access to us through those. So I'm happy to answer any questions. Another thing that I wanted to share with you quickly is that we have a patient partner network. I've mentioned multiple times already. We have about 7 patient partners that are currently engaged with our patient partner network. This is a screenshot. I know it's a little confusing, but this is a screenshot of us in a Zoom call focus group with Ariadne Labs on one of the times that we have joined them to discuss team birth tools. So this is just an example of one of the things that we have done over the last couple years as a focus group. And we are open to doing other engagements. If anyone is interested in engaging with our patient partner network, you can use this QR code and fill out the Google form. And I will be in contact with you to set something up. We're open to doing whatever. We've reviewed documents, we've done focus groups. We can share stories, and we're also looking for patient partners. And that's something else that you can email me about. We're always recruiting. So yeah, I think that's pretty much it for me, Denise. Yeah, the next is Melissa. So if anyone has any questions, feel free to reach out. And I appreciate you guys giving me some time today. And I'll turn it over to Melissa.
I'm going to
Great, thank you, Sarah.
say thank you first to Sarah, and please reach out if you have questions. I put her email in the chat, and we will also follow up with the information in the follow-up email, and all of this stuff is on our website. So we hope that people will engage in this. We have certainly seen, as a member of the Maternal Mortality Review Committee, that sometimes patients may not know how or when to seek help. So that information is really important with our the program that Sarah and the patient partners have developed, and they're really a helpful group if you need anything with patient perspective. So thank you, Sarah, so much. And I'm going to turn it over to Melissa Ward, who joined our staff in May and is wanted to provide you all with an update on our low-dose aspirin and pregnancy initiative. I want to say, first of all, as you look at all these resources, there's a woman in the UK who her area of expertise is patient adherence to medication, and they have conferences on this and everything. Anyway, she had seen our toolkit, and she was highly complimentary to Melissa and the work that she's done, and that she's addressing every single angle on how to work with providers to increase patient adherence. Not only do we need to just recommend aspirin, recommending isn't enough, just making sure that they are aware of why I'm using we have all the tools that you need so that we can ensure that they're actually taking the aspirin. That's the important thing. So go ahead and I'll let Melissa provide you with some updates.
All right, thank you, Barbara. Yep, I'm just going to update based on what we talked on last time we met. Denise, if you would change the slide for me, please, which was on 10/17. So it feels like a lot has happened since then, but that was our last quarterly meeting date. And I did my presentation for you all at that time. If you were not on that meeting or have not seen the presentation, I partnered with OHCA to do a moderated webinar, and that is available on our website at your convenience to view. So of course, the aim of this initiative is really just to reduce rates of preeclampsia and improve birth outcomes in Oklahoma. We know we are lagging in terms of some of our measures when it comes to reducing rates of preterm birth. We did make a big impact last year, but we still have room for improvement. And of course, we do have high rates of preeclampsia and gestational hypertension in Oklahoma. So about 1 in 11 Oklahomans do experience gestational hypertension or preeclampsia, and that's based on 2022 numbers. So I'm really interested to see once we get that 2023 number, if we've made any additional impact. But in order to meet our aim, of course, we need to increase the provider awareness of some of the 2021 guidelines that came out in regards to who is eligible for low-dose aspirin therapy. I participate in a lot of different calls, one of them being like our OSU Echo maternal health calls, where I continually do see that this is one of the things that enough providers are not aware about some of the expanded guidelines, whether it be patients who experience obesity, they are at moderate risk for developing preeclampsia. And then you combine that with it's the first time they've ever had a child, that does put them at high risk to experience preeclampsia and some other complications. So we need to ensure that providers are aware of those guidelines. Secondly, informing clinical and non-clinical maternal caregivers of the benefits of low-dose aspirin and the importance of medication adherence. We have a lot of wonderful community care workers out there that are doing great work and working with some of these individuals in the community who maybe need a little bit more extra education or support during their pregnancy. And so we want to ensure that they're able to direct patients to the appropriate information or are able to answer questions that they might have when it comes to taking low-dose aspirin in pregnancy. And then, of course, we just need to improve public awareness of benefits and safety of low-dose aspirin. There's still a lot of people that are healthcare workers also that based on what they do in their profession, whether they work in neurology or cardiology, you know, maybe they're not aware that low-dose aspirin is something that's safe to take. So we need to improve that awareness and just provide better education for the general public. Slide. So how are we doing this? Well, of course, we created a toolkit that was presented at our last session to assist clinicians in patient screening and to help them improve that patient education piece and discuss the importance of medication adherence. With low-dose aspirin, you need to take it at least 90% of the time for it to be effective. This is different than most other medications that you may take for a chronic health condition. Usually those need to be taken 80% of the time for you to get a benefit, but with low-dose aspirin, it is important that it's taken 90% of the time. So really focusing our efforts on educating the public about that. I did send samples of our toolkit to all OHCA contracted OB/GYN clinics in Oklahoma. So I did a data request from Tram. She has been wonderful in helping me get some of that data. And I sent samples to all of those clinics. And then now I'm in the process of verbally contacting all of them through the phone, trying to get email addresses of some of the clinic managers so I can send them direct links to the toolkit. And then lastly, I'll be doing in-person visits. So anybody that I was not able to contact directly, you know, just dropping in the clinic, dropping off some materials, hopefully being able to get some FaceTime with the clinic managers at that time. I've also had this initiative published in numerous newsletters throughout the state. So thank you to all of you that have helped support that, getting this message out there to the public and also to the different types of clinicians, whether they be nurse practitioners or physician's assistants, and some of our other public health partners that are doing work in the community. And then we've also done a lot of presentations. I presented at our annual summit for OPQIC. We had a great discussion with some of our nursing leaders about low dose aspirin and who's eligible for it and who isn't, and kind of discuss, you know, what are some of the barriers to care for that. I've presented to doulas and other community groups. So it's been a wonderful opportunity to get that message out there. Slide. I've also been doing a public awareness campaign, and it was great to hear Joyce talk about their efforts with their awareness campaign at OSDH. OPQIC is running one as well. And so this is the type of messaging that is going out. I've changed it out monthly, and the target audience is female between 18 and 55 years of age living in Oklahoma. And since October 11th, we've had over 240,000 impressions and 6,500 link clicks. So we continue to see a lot of interest in what we're doing with this campaign. Slide. So how can you help? Well, one of the biggest barriers that I've had was just getting some of the face-to-face time with physicians to discuss this initiative, to share the toolkit, to talk about not only just providing some of the materials to the patient at the time that you're prescribing them aspirin, but also continuing with that follow-up at each appointment. Medication adherence is a big challenge in the US, and it's responsible for billions of dollars that have been spent on healthcare because patients don't know how to take their medication, or they don't take it appropriately or understand why they need to take it on a daily basis and not just when they're starting to feel symptoms, right? Because the biggest thing with this is that low dose aspirin is the only known way that you can actually prevent preeclampsia. And you can't do that if you're not taking your medication on a daily basis. Also, sharing this toolkit with any clinicians you know, or any other healthcare workers that are working with people in the community that are thinking about being pregnant or would like to be pregnant in the future. You know, we need to get this message out there that aspirin is safe for use in pregnancy as long as it is low dose. And it's not something that's just taken to treat a headache or something. This is a daily aspirin for the prevention of preeclampsia. Also, if you know anybody that's pregnant, just do a little bit of fishing, I would say, and just say, hey, has your provider ever talked to you about aspirin? I know I was talking to somebody just last week about this, and we were kind of wondering, you know, when is this provider going to bring it up? Because we know that that person would probably be put into that high risk category for low dose aspirin, but they're not pregnant yet. So, you know, just speaking to people and kind of finding out what's the sentiment regarding aspirin in pregnancy? Do they have concerns about it? Has their provider ever spoken to them about it? And then, of course, another way that we can use your help is just to follow OPQIC and share our social media posts, like the one I just showed you on the previous page, getting that message out there to the general public and the people that you know. So if you are interested in getting a presentation to a group that you work with that works in this maternal health space, or if you are wanting professionally printed toolkit materials, I am able to do both those things for you. So you can just email me and let me know just when you want me to come and present to your team, or if you would like any of these printed toolkit materials. I have lots of money in the grant for this that I can ship these materials out to you so that you can start using them in your space. And of course, you can always access our toolkit anytime. All materials can be printed for free. And also, you can view the presentation I previously recorded on there if you are not able to get me in person for some reason. You feel free to share that with those that you practice with. Does anybody have any questions? Okay. Well, then I'm going to turn it back over to Barbara.
Thanks so much, Melissa. Yeah, so please reach out. Melissa is available to talk about the toolkit with your practice. We've had great responses from Variety Care is using them and other clinics that they've been very helpful to talk with your patients and educate them on aspirin and pregnancy and why it's important for them to take it. And the resources do a lot of that explanation for you. So Melissa would be happy to talk with you all or anyone else about the low-dose aspirin and pregnancy resources that we have. I do want to mention a couple, at least, two available resources that we believe are critical to your care. The first one, the Amniotic Fluid Embolism Foundation has recently developed some tools for clinicians. If you're not aware of amniotic fluid embolism or anaphylactic syndrome in pregnancy, it is a reaction, often occurs at right around the birth, and we don't really know what causes it, and therefore it's hard to prevent and can be very challenging to treat as well. So just want to share this information with you all so that everyone has this. There's 3 simple things that I'm asking you to do. The AFE Foundation, I will tell you, they are an excellent resource for you. And Miranda Klassen, their founder and executive director, can be extremely helpful for you if you have any questions. So their mission is to reduce maternal and infant mortality attributed to amniotic fluid embolism while helping those impacted navigate paths forward. I do want to say that they are very helpful to families and to clinicians. For those of you who have not, often the presentation of a woman having an AFE is sudden cardiac collapse. And the mortality rate from this is up to 40% and even higher, depending on what resources are available at the resources available at your hospital. Luckily, it's very rare, but again, we don't really know who's at risk for this. So they're doing a lot of research to try to find that, and you can help impact that, the research. So next slide, want to also talk about some of the research that they're doing. If you suspect that you have an amniotic fluid embolism, a patient who has experienced that, even if you're unknown. I think I'll show you on the next slide how you can contact, but we do want to have expand the database of AFE cases for the research, so that hopefully we can come out with some, identify risk factors and be able to know who might be at higher risk, and improve ways that we can treat the amniotic fluid embolism. So when you do have a patient, one of the critical things is to sequester specimens. So it's very timing, the timing is critical, I should say. So they need a red tube and a lavender tube collected at collapse prior to transfusions. So that's one key thing. They can also use other blood tubes that have already been collected, and also placental tissue, but those having those tubes blood available for research is very helpful. This is the main thing I want you to know. If you look at the next slide, the AFE hotline. So this is a HIPAA compliant hotline that if you suspect your patient is having a AFE, so if you have any patient that has a sudden collapse, cardiac collapse, call this hotline immediately. You will be connected with an expert clinician on AFE, and they can guide you in treatment and management of your case. They can also talk to you about specimen collection, and they also provide excellent crisis support for the patient, the family, and the clinical team. So please put this number on your crash cart. This is something that we want to communicate to everyone, to call the AFE hotline if you suspect that your patient has had an amniotic fluid embolism. The next slide goes into some more of their resources that they have. They have resources for patients. They have communication checklists for providers, and looking at whatever the outcome is for the mother and for the infant, they have specific guides for those. So this is helpful for patients and for clinicians. And then looking at the next slide, they have a website where you can access all of this information at amnioticfluidembolism.org. So I would suggest you visit that. The other things that you can access if you visit this website, if you look at the next slide, Denise, they have developed a new course on an online course on AFE and a practical approach. It is free and is available to clinicians to take. So I would encourage you to have some of your providers and nurses participate in that course. The next slide, also a new toolkit that they've developed, is a simulation toolkit. Tells you, can guide you through how to have a simulation. And, this simulation is helpful for anyone who would have a sudden collapse that you need to resuscitate. So this again is another helpful resource for you. It does have this checklist on the next slide that focuses on the 3 B's. They call it the breathing, blood pressure, and breathing, blood pressure, and bleeding. So this page here could be something you have on your crash cart. It has the AFE hotline number as well. So key takeaways, our last slide about this: if you have a suspected case, call the AFE hotline as soon as possible. Utilize the 3 B's checklist for your initial response, and then access the free support and educational resources. We just wanted, these tools are new. Just very recently, we wanted to make sure that you all are aware of these tools. So we will again be sending this out in our follow-up email, but want to tag any opportunity if anyone has any questions. Luckily, the incidence is very, we probably have one per year in Oklahoma, but it has a very high mortality rate, and it can happen anywhere to any patient anytime. So I want to make sure that you all are aware of this resource so that your units can be ready to respond. And the last slide here for resources, I want to make sure that everyone's aware of the maternal mental health hotline. We've talked about this before, but every patient should be given this information during pregnancy and postpartum. Again, this is a 24/7 hotline that is available. Please, we encourage you to refer your patients to this hotline. It is available on Sarah's tool that they created. So if you use that, this is one of the things that you will be giving them. And also to know that if you are having someone with a mental health crisis, to access the National Suicide Prevention Lifeline at 988. So this is similar to calling 911 for a medical emergency if you call for a mental health
You can
emergency.
just,
Go ahead, Teresa. Did you have something?
Sorry, that was my grandson.
Oh, okay. Well, it was pertinent to the Department of Mental Health, so I thought you might have something to add. But I know there were I just saw an article recently about how many people they have supported in Oklahoma utilizing this 988 number. So we would encourage all of you, for anyone that's having a behavioral health crisis, to contact this lifeline at 988. And I think that is all of our agenda items. Are there any questions or other business that anyone has at this point? Hearing none, we will send you all a follow-up email. The next slide, want to make sure that you're aware of how to register for the quarterly meetings. You can do it one time if you go to this site, and you can sign up to get the invitation sent to your calendar. Our next meeting date will be April 16th. And at that, the one in April, we usually have a legislative update. So we will be working on securing that for you, because we will be in the middle of our legislative session at that time. And then after that, July 16th. Thank you all for being here tonight. I think for our last slide, we have a couple of upcoming events. If your hospital has not registered to attend the in-person teen birth implementation workshop, please join us on February 8th at the Samus Education Center. You can go to our website to register. And again, to remind you all about the OSU Project ECHO maternal health calls on the first and third Thursday of every month. And you can access that through the Oklahoma State website. And please follow us on social media. Here's our slide with all of our ways to engage with us. And we thank you all for joining us this evening. And I'm sure we will be talking with you soon. If not, and otherwise, we'll see you in April.